Okay, thank you again, Anusha, for your kind introduction. And today I'd like to talk about diffusing the time bomb in your head, preoperative evaluations and surgical treatments of postal tinnitus. I'm very pleased to share my humble experiences on the diagnosis and management of postal tinnitus. So today I'd like to talk first about diagnostic workup for postal tinnitus, such as audiological assessment and spectral temporal analysis. And then I'll talk about diagnosis and treatment of individual diseases such as Glomus tympanicum, aberrant internal carotid artery, jugular bulb dehiscence or high riding jugular bulb, sigmoid sinus diverticulum and dehiscence, and dominant sigmoid sinus with focal thinning and dehiscence. So first part, diagnostic workup for postal tinnitus. Postal tinnitus is a sensation of hearing a rhythmic noise such as heartbeat, swooshing or whooshing from no external sound source. And for many, the near constant sound becomes completely debilitating like a time bomb. So several potential mechanisms of postal tinnitus perception has been suggested, such as an alteration in the vascular hemodynamics may cause turbulent blood flow and lead to sound transmission, or vibration of a dehiscent vascular wall even in the absence of turbulent flow, and sound transmission from third window lesions in the inner ear. So a recent study published in China found that flow field characteristics or wall pressure are quite different in patients with sigmoid sinus diverticulum. Here comes a question. Is postal tinnitus always objective? I don't think so. According to the Cummings textbook, objective tinnitus is subdivided into postal tinnitus and non-postal tinnitus, which I don't agree because only 20% of vascular postal tinnitus is objectively detected by clinicians. And in my personal experience, even less than 10%. So that's probably why TRI flowchart divides tinnitus into postal tinnitus and non-postal tinnitus, and there is no term such as objective. There are several basic diagnostic steps, such as detailed history, physical examination of the head and neck area, including auscultation, and audiological evaluation, and radiological evaluation, such as temporal bone CT, temporal bone MRI, and angiography. That being said, there are wide discrepancies in the incidence of abnormal findings. For example, some researchers reported that intracranial hypertension is the most common cause of postal tinnitus, but others said that anatomical variants or abnormalities of the venous system or dural AVF or arterial stenosis are the common causes. Also, nearly no abnormal findings were found in some reports, but others reported that abnormalities have been found in nearly 100% or about 90%. And the probable cause of the differences in reported incidence are the uncertainty as to whether the radiographic findings are indeed the etiology of the patient's tinnitus or just incidental. For example, we can easily find high riding jugular bulb in temporal bone CT scans, but we are not quite sure if the findings are incidental or pathognomonic. So in this regard, we need other methodologies for proper diagnosis of the etiology in subjects with postal tinnitus. We found that in patients with postal tinnitus, ipsilateral pseudo-low frequency hearing loss, regardless of the etiology, due to the masking effect of the postal sound and its normalization after surgical or interventional managements are found. So in my data, about 26% presented with an ipsi lesional low frequency hearing loss, and we reported the results several years ago. And also, as a sequel study, we found that the presence of ipsi lesional pseudo low frequency hearing loss and its improvement after manual compression confirms the vascular origin of the postal tinnitus and predicts a favorable surgical outcome in patients with postal tinnitus originating from the sigmoid sinus diverticulum or dehiscence. So here in the graph, you can find the pseudo low frequency hearing loss in the ipsi lesional side. And the pseudo low frequency hearing loss is nearly normalized when you compress the neck, the ipsilateral jugular bulb, jugular vein, and also postoperatively, the pseudo low frequency hearing loss is normalized. So to develop a objective recording method, we used a transcanal recording method, and we used a small condenser microphone connected to a rubber canal ring. And the sound was transmitted from the EAC to the condenser microphone all the way to the preamplifier, audio interface, and saved to a laptop as PCMA format. And the signal recording was performed using a software called Cubase, and signal analysis was performed with MATLAB. So by performing this analysis, we could record a very salient rise and fall patterns in patients with tinnitus, regardless of the pathognomonic lesions. Whereas we couldn't find those kind of stark rise and fall patterns in in controls. And also by performing spectral temporal analysis, here you see the x-axis is the time, the y-axis is the frequency from the low frequency to the high frequency, and the z-axis is the sound pressure level. And you can find the very stark rise and fall patterns in patients with tinnitus, but you cannot find those kind of patterns in controls. So the results were published 6 years ago. And as a sequel study, we also performed pre and post-operative comparisons and find that the preoperative rise and fall patterns are nearly normalized, and there is no statistical differences with controls. By performing pulse-synchronized spectral band analysis, we found that the significant differences are found mainly in the low frequency regions, and this is probably why patients present with low frequency hearing loss. Now let's switch gears to diagnosis and treatment of individual diseases such as Glomus tympanicum, aberrant internal carotid artery, and jugular bulb dehiscence or high-riding jugular bulb. So Glomus tympanicum can be easily visualized by autoendoscopic examination. You can see a small pulsating mass in the tympanic cavity, mainly in the posterior inferior quadrant. And it can be easily visualized by temporal CT scan. And by performing spectral temporal analysis, you can find very stark rise and fall pattern coming from the EAC. So by performing preoperative TFCA, you can visualize the mass, and you can embolize it if the feeding artery is big enough. And by performing transcanal endoscopic or endoral approach, you can remove the tumor, and tinnitus is completely resolved right after the surgery. Aberrant internal carotid artery is not the true internal carotid artery, but rather a hypertrophied inferior tympanic artery arising from the ascending pharyngeal branch of the external carotid artery. And it can be best appreciated on temporal CT scans since one can see the bony landmark. So here you can find the elongation of the internal carotid artery, which is not the true internal carotid artery, but a hypertrophied inferior tympanic artery. So a friend of mine, Dr. Moon, found a very nice way to remove the tinnitus sound perception. He inserted a bone chip in between the intercarotid artery and tympanic membrane and reported a very nice result. And also, Japanese folks reported a TM lateralization procedure to improve the tinnitus perception. Jugular bulb dehiscence or high-riding jugular bulb, by definition, it extends over the tympanic annulus and the round window or the basal turn of the cochlea, or it extends to the level of the EAC. And some colleagues of mine, Dr. Park, reported that the most common abnormal finding in patients with tinnitus. So here you see a case, a female 50-year-old right tinnitus due to high-riding jugular bulb with dehiscence. Here you see the dehiscent portion of the jugular bulb. So I performed a jugular bulb resurfacing surgery. So first, I made an endoral incision. Here, veer discretion is advised. So after elevating the tympanometer flap, I could visualize the dehiscent portion here. And first, I placed a piece of tragal perichondrium and then placed several pieces of bone cement over the dehiscent portion and waited for a little bit until the bone cement sets. And I replaced the tympanic membrane and finished the surgery. So here you see the reconstructed portion of the jugular bulb wall, and the symptom was much abated right after the surgery. So this is the schematic illustration of the surgical procedure. You first find the dehiscent portion, and first you place a piece of tragal perichondrium and then cover it with several pieces of bone cement. Now let's switch gears again to sigmoid sinus diverticulum or dehiscence and dominant sigmoid sinus with focal thinning or dehiscence. The definition of sigmoid sinus diverticulum can be summarized as irregularity or of the normal semicircular contour of the bony sinus wall, focal thinning of calvary cortex overlying the adjacent sinus wall, or absence of the normal thin layer of the cortical bone overlying the sinus, or the air on sinus sign, which designates mastoid air cells directly contacting the sinus wall. Here you see a case of mine. So she's a 36-year-old female complaining of left postal tinnitus for 7 years, and preoperative audiometry revealed left-sided pseudo low frequency hearing loss, probably due to the pulsatile sound, and it resolved right after neck compression. So here you see the defect of the calvary cortex, and also you see the air on sinus sign. And I performed sigmoid sinus resurfacing surgery for the patient. Viewer discretion is advised again. So I first made a retroarticular incision and harvested a piece of temporalis muscle fascia and elevated an anteriorly based periosteal flap. First, I performed canal wall up mastoidectomy to skeletonize the sigmoid sinus. Here, you should be very careful because if you open up and tear the sigmoid sinus wall, you may encounter a huge amount of bleeding. So what I do here as a surgical tip is to leave a small piece of soft tissue island to cover the sigmoid sinus diverticulum. And further skeletonization of the sigmoid sinus is performed. Now you see the dehiscent portions. So there were two diverticula. So now I'm ready. So I place two pieces of fibrin sealant. The commercial name is Tacocom or Tacoseal to compress the diverticulum. Here I encounter a little bit of bleeding, but the bleeding is easily controlled. So after confirming that the diverticulum is normalized and onto the layer of the sigmoid sinus, I place a piece of temporalis muscle fascia and then I cover it with a bone cement. So this is a schematic illustration of the sigmoid sinus resurfacing surgery. So first I skeletonize the sigmoid sinus wall and compress it to the contour of the sigmoid sinus and cover it with a piece of temporalis muscle fascia and cover it again with bone cement. So after the surgery, you can see the normalization of the pseudo low frequency hearing loss because the postal tinnitus is gone. You can also see the whole video clip at the YouTube channel called Smart Surgeries. So I performed a live surgery last year, so you can see the whole video clip. Last but not least, I'll talk about the dominant sigmoid sinus with focal thinning or dehiscence. So here you can find very severe asymmetry of the sigmoid sinus with focal thinning or dehiscence. But then again, you should be very careful because the symptom should be correlated with the radiological findings. Because in a recent paper, they found that in subjects without postop tinnitus, sigmoid sinus dehiscence was found in as much as 34%. So this is the summary of the sigmoid sinus reshaping surgery. First, I harvest a piece of bone chip, and then I perform the simple mastoidectomy to skeletonize the sigmoid sinus. And once I find the dehiscent or thin portion, I make a hole here and insert the bone chip and cover it with a piece of temporalis muscle fascia, and finally cover it with bone cement. So this is a schematic illustration. So here you see the thin or dehiscent portion of the sigmoid sinus. And by inserting a bone chip and cover it with bone cement, you can disconnect the bony conduction route by performing simple mastoidectomy and reinforce the sinus wall with bone cement. And we also found that by performing long-term follow-up study, we could find that the improvement of the symptom is maintained for a long time. So to wrap up my presentation, detailed physical examination, including auscultation, should always precede imaging workup. And pseudo low frequency hearing loss and its normalization by neck compression and transcanal sound recording and spectral temporal analysis may help in objective measurement and treatment outcome evaluation. Temporal bone CAT scan may provide a lot of information, but brain MRI or MRA or conventional angiogram should be performed in selected cases based on clinical suspicions. Radiological abnormalities should always be correlated with clinical symptoms, but you shouldn't over or underestimate incidental findings. And once accurately diagnosed, the pathology can be corrected in most cases. So for take-home messages of the talk of mine today, postop tinnitus originating from the sigmoid sinus or jugular bulb can be successfully managed in most cases if properly diagnosed and managed. And preoperative audiogram with and without neck compression and transcanal recording may be of help to select proper surgical candidates, and reducing local turbulent blood flow and making a soundproof barrier are mainstays of successful surgical treatment in subjects with postop tinnitus originating from the sigmoid sinus or jugular bulb. Thank you for your attention.